Conference recording started.
I think you can minimize that screen. This one? Yeah, you can just minimize it. Yeah. Okay, let's see. Now we did that, right?
Okay, so click yes.
Yes.
Right here, click here on that green thing.
Okay, this is Martha Ackman from the Hospital Quality Institute, and I just want to give a little reminder to our presenters today. There's quite a few of us on the line. That is that when you're not speaking, you might want to put your phones on mute just because everybody will hear all the background noise. So welcome. This is Martha Ackman from the Hospital Quality Institute, and I'm here to welcome you to our 5th webinar in the Preventing Patient Falls with Harm coaching series. It's been a fabulous journey with our subject matter expert, Pat Quigley. Thanks to each of you for your continued support and engagement. And I do hope that you have found this series as insightful and energizing as I have. So I'm going to start with the first polling question and ask who's in the room. I'm hoping that today perhaps we'll have a few more frontline staff as we are going to be hearing a couple live stories. But either way, we're glad to have you here. So just if you can note where what category you are from, we will really appreciate getting that feedback. So just one more second. And I think, Shweta, we can go ahead and we can close that poll, and we can see that the majority of the participants are from management, but we also do have a few from the other category. So hopefully we'll be able, we have some other people in for the learning today. The next polling question, we want to get an idea or a finger on the pulse of what of the different practices that have been presented throughout the series have been adaptable to your organization. So since participating in the Fall Coaching Webinar series, I'd like you to respond with, we have implemented either identification of falls as accidental, environmental, or physiological. As you may recall, Pat shared how to categorize the falls early on in the webinar series. Also, if you've instituted post-fall huddles, and in those huddles, if you're including the patient and family in that, because they, as we know, most of our patients are getting up even and maybe not falling other times, so we really want to know what happened differently. Also, what other injury reduction strategies you've been able to implement. If you've looked at proactive toileting, you're doing that. If you've done anything with bathroom redesign, and also identification of unit champions. So if you just would identify there where you're at, that would be great. I can see that we have a couple of people that are using the new categorization or different categorization of the types of falls, and then also a couple on the proactive toileting, as well as some that have done selective interventions with the post-fall huddle or harm reduction strategies. So our goals, sorry, I went too fast here. Goals for the series that you can see here, and we've gone over these each time, but really to extend the application of fall and fall injury prevention interventions to specific populations, to restate the critical program elements to reduce repeat falls and preventable falls, and to compose strategies to reduce the barriers and enhance facilitators to short and long-term program implementation. As you can see, this is how our webinar series has been laid out. We started with the post-fall management. Then we talked about protecting our patients from injury, utilizing unit-based champions. Then we went to proactive toileting, mobility issues, and hypotension were touched on last time, and we will have a little bit more information on that this time. So, but the real treat this time is, much as Leonardo da Vinci says here, knowing is not enough. We must apply. Being willing is not enough. We must do. And I can tell you that you are in for a real treat today, as 3 of your colleagues are prepared to share their improvement journey. So they are doing. These stories are very rich in that they really reflect the lived experience in healthcare today. So we're going to start out with one of your colleagues, Will Morrell Stinson from the Palmdale Regional Medical Center. So I turn it over to you, Will.
Thank you very much, Martha. Hi, everybody. As you can see, that's a picture of our hospital that's in the desert of California. It's a 156-bed hospital with a daily census between 110 and 130 patients. That's a fairly new hospital. It's only in its 6th year this year, but it's got a fully functional ED. Sees about 72,000 patients per year, and we have everything except for labor and delivery and pediatrics. And at the top floor that you can see there, that is a shell at the moment. We're going to be building that out at some time in the future. But if you look on the very left-hand side, there are 2 flags there, and that's a brand new rehab unit, and that's going to open in November. So if I go, what we did, after the workshop in April, we were very, very excited. We asked ourselves, did our staff truly actually understand the reason for the high fall risk? Or was it just another task they had to do, just another number they had to do that? Because you know what? We tried everything. And we knew, you all know the definition of insanity, we were not going to go that way. We were willing to try something again. And it was good because we changed our approach. We spoke to our staff, and I'm going to show you on the next slide the buckets, but they're the high risks that we learned at the workshop, and it was to be helpful to the staff because we wanted to be proactive and not reactive. And this is what we did. We created a huddle, and we took the stop sign is stop, listen and watch. And from where Pat explained the environmental, the known risk factors, and the unknown sudden conditions, so the staff could understand if a patient's got a Foley in, he actually becomes an automatic fall risk because he can fall tripping over the tubing. So we ran this every day, every morning. We put it in the huddle, and then what we did from there onwards, when a fall did happen, and you'll see there's small lettering, that is just the usual thing everybody does. But what we did different is we actually, speaking to the patient, instead of making him feel guilty, we said, what was different this time, which made him fall? And that is something, when Pat gave that to me, it was like, wow. Let's involve the patient totally, and then also give him the option of being in charge of his own life, in a sense, is what can we do better to avoid a future fall? And the other part we did is we actually talked to the nurse. Did he or she truly understand the reason for the risk that the patient had to a fall? And did she actually assess the patient, or did she simply screen the patient? Because, we all know the Morse score, but that is not a reason for a fall. So that is what we did. And then after that, a couple of things we did. We did the daily the tricks and tools. That's a tongue twister today. As I said, the daily huddle. Then on a monthly fall meeting, we struggled at first to get a champion. And then we found a nurse who, when her patient fell, she was horrified. She did everything she thought she could do. And when she understood that her fall was an environmental fall, she was then keen to do something different. She wanted to know what else could she do. So, and she's given us a lot of good info, and I'm going to share that with you a little bit later. Now, at our monthly meetings, we discuss things and we get feedback. For instance, the adjustable commodes. Our staff was not even aware of the fact that they could adjust the commodes. So that was a big one. So we put a huddle out for that. And also, I'm cautiously optimistic. This month we showed also specifically the education of, document education, and our falls have dropped and our education has gone up. So there's a direct correlation, and I really, really trust that that will carry on. But the big thing that we wanted to do is to stop blaming the patient and saying, but the patient's uncompliant, he didn't want to wait for the nurse or whatever, but make it our own. Not to blame ourselves, but to make it ours. What can we do better to make it keep the patient safer? And over here now, we have what we call a RDE, which is a remote documented entry, and that is if things happen that should not have happened. And these are the questions we are now putting in. The nurse actually needs to put in that RDE. Did the nurse know? Was the SBAR handoff handled correctly? Was the fall assessment done versus the screening? We have an IPOC, which is an integrated plan of care. Was it based on the reason for the risk? And as I mentioned earlier, the education being documented, and then the usual things we usually do, the post-fall assessment, the huddle, the PT evaluation, the family contacted, and then we categorize it there. And every month we have a run chart to see how many times was it an environmental fall, or was it a known risk factor, or was it an unknown risk factor. And this is the graph that we did, and I just want to show you there the month of April we implemented. After April, we had no injuries, May no injuries, June no injuries, and so far July no injuries with our falls as well. But our number of falls are also coming down. But I know it's something that Pat had mentioned, that falls do take place. We just got to make sure we keep them safe. And that's the part that if our staff can have the understanding why we got to keep them safe, then we will keep them safe. And that's a short and sweet version of it. If you have any questions, go for it.
Will, that is excellent. Thank you so much for sharing that. You had so many really rich points there, just on the sharing the different categorization of the fall, engaging the unit champion. That is really, I know that some hospitals have had some challenges in finding unit champions. So could you just take a minute again to talk about how you identified your unit champion and got them engaged?
Sure. It was extremely difficult because when I asked for volunteers, I got, of course, no answers. And then because all of them thought, no, but that's a punitive thing. And we said it's not. It is for you guys to help your co-workers on when things go wrong so we can help each other. And still, I got no takers. And then when this nurse, she's one of my absolute stars. And when her patient fell, he had a Foley in, he had SCDs on, and he had an IV. And the IV got tangled, so he leaned across. He wanted to get something from his table, and you can imagine what happened. And she was so horrified. She says, I need to be part of this because I know that I did everything I could. But we even educated the patient. But she felt that there must be more, and her being in, and she came to our next meeting, and that was also, she gave us the down-to-earth information. Like, for instance, when an RDE needs to be done, what do we want to know? And from our side,
Whoops.
Okay, she's taking it back to her coworkers. And so now the other units, we are all going to bring at least one person in. And the best person to pick is somebody who had a fall, because they will know what it's about.
Great. Well, thank you.
Well,
That is
this is Pat Quigley's voice. Can you hear me?
Yes.
Yes.
And Martha, I join you, Martha, in congratulating Will and your team for all the great work that you're doing. And it, as you, even though it's a brief presentation, you have so much depth and breadth to your presentation and really going after the types of falls. I mean, you're going to have so much more precision. But I'd like to congratulate you, too, on that you actually went after structure and process to be able to achieve these outcomes. And everything from, what you're doing to even reducing those repeat falls by the post-fall huddle. So I just wish you so much success in it. And what I also hope is that you're keeping a timeline on the interventions that you implement for your program, because that's really the story. And a lot of the organizations that try and publish their success in trying to reduce their falls by type of fall, which is very little literature on, they don't keep track of the timeline for like when you decided to go after that post-fall huddle or when you decided to go ahead and adjust the height of the toilet seats, all of those great things that you're doing. So I just want to say congratulations and well done. I'm going to look for your article to be published, okay?
Thank you very much.
So there you go, Will. You thought I was a hard sell. So, so
if
I'm
you need help with the article, let me know.
I want to keep us going here. And again, thank you, Will, for sharing those 5-minute updates. I think that's a great strategy too, because and as you and I have talked about, that's a way that you get the information across quickly to the frontline staff. So thank you so much. Our next speaker will be is Valerie Martinez. She's the Director of Quality, Patient Safety, and Infection Control for Palomar Health, which is a multi-hospital system here in Southern California. And so, Valerie, I'm just going to hand it over to you, and you can go ahead.
Sure. Thank you, Martha, and thank you for having me. Normally I believe Bunny, which is the clinical nurse specialist, Bunny Krall, who works for me for quality, she wasn't able to present today, so I am stepping in, and I'll see if I do her some justice. We are both very passionate about this. She has been the lead on this, but I've been there right there with her. So we affectionately call this blooming in bloom, because what you'll see the sunflower there, and it'll give some more meaning to it as I go into the presentation. And the system here is Palomar Health is a 3-system hospital, or with our newest hospital was opened up in 2012 as a 288-bed level 1 trauma center. Then we have our older hospital, which we're going to be closing, and that there is your psych, inpatient psych, OB, and pediatrics and mental health, and then our smaller hospital, which is 108 beds, community-based hospital. So just to give you a little idea where we are. When we did this, we actually went standardized across all 3 hospitals where we were able to. So this is a full system 3-hospital approach that we did. As we go into it, you'll see a little bit more what we've done. So first of all, we actually pulled our team together. We pulled an interdisciplinary team together with frontline staff, clinical frontline staff, as well as non-clinical, and some leaders, and we did really what we've called a deep dive, just looking into our systems and processes, where we were, what we have done, and where we need to be. And as we went through that, we realized that that we were not as standardized as we could be, and can we standardize. So we had all these different interventions on visible cues that a patient's at fall risk across the system, that when you have so many, there's really nothing, and staff just don't understand. And what does this yellow thing mean? What is that? So we were able to, when we met, we talked to the staff, we mapped it out, saying, showing what we have and what can we really get to, to show a visible cue that when a patient is at fall risk. So as you see, there is a yellow falls wristband. So all patients who are falls will have that. Will get that yellow wristband. So the theme is yellow, obviously. And then the yellow socks. So we have these yellow socks, and these were some of the things that we did before, but we did so much more stuff. And now it's just these 3 are the visual cues. And then the sunflower on the door. This was, and that's when we say blooming. One of the units actually piloted this sunflower, and what happened was at our larger hospital, it's a long hallway, so we would have these lights above the door, and you couldn't really see them. They were a yellow light, and it turned on, and then you have kind of these sliders that you kind of push the little slider from one side to the other, and it says, at risk. And really what it was at fall risk. But you couldn't see it when you're when you're looking down the hallway. In our other hospitals, you couldn't see any of the other stuff either. So what we did was she piloted the sunflower on the door, and you look down the hallway and you can see the sunflowers, and that really is to tell that the patient is at risk. So these three are identifying fall risk patients, and that's it. We don't have anything else for the visual cue. And then for our psych units, we just have a placard. We don't have the flower there. Moving on, we did stick with the leaf behavior expectation. So, we do have the leaf right here on the sunflower, as you can see. So what it is, as you know, looking, so anybody walking by, it doesn't matter what your discipline is, whether you're a senior leadership, the CEO, all the way down to, the frontline staff, this is the expectation that we expect from all our staff. So leaf, looking into the room, walking by, if they see that sunflower, making sure that the patient's okay. Evaluate and enter, so if they see the patient maybe calling for help or trying to climb out of bed, the expectation is that they will go into the room. They will alert the nurse, so the patient is trying to get out of bed, they will push that call light, alert the nurse to get them to the room. They will stay there, follow through with staying there with them. So that is the expectation. In addition to all the staff, this is the expectation of the medical staff as well. So we took it from when we did our education and rolling out the new standard process, we went from the frontline staff education all the way up to our senior leadership, CEO, medical staff, and our board. Moving on, we also implemented what we call Code Sunflower, and really what it is an extension of the rapid response team. So if a patient falls, then emergency code with the patient fall, so they'll do it just like they would call an RRT or a code blue. They'd push the light and they would tell the PBX operator, Code Sunflower, room 452. The rapid response nurse does respond. They'll provide support to the bedside RN and patient assessment. So those nurses are, your critical care nurses, or some of them are trauma nurses, so they are giving more support and helping with that patient assessment. Do they need some kind of scan, x-ray, things like that, helping them with that patient and providing that support at the bedside. So we did a 1-month pilot to see how this would look, how it would work. Should we just roll it into our RRT and call it RRT, or should we make it separate and call it a Code Sunflower? We decided to call it the Code Sunflower, so there is that heightened awareness that something as, a patient has fallen. So here, Sunflowers in Bloom. So when we kicked it off on July 18th, that was our day, because as you can see, yellow is the color. And so these are all nurses and staff across including our vice presidents and frontline staff and leadership, just showing their support for fall prevention. And so that's it. I was just giving you a brief update of it. We don't have the data here. I'm not sure we didn't put that in. I apologize for that. We can certainly tell you we have seen some reduction in our falls. We certainly are not where we want to be. We're looking more at, not preventing all falls, but certainly preventing the level of injury in that. So we do have heightened awareness. In addition to this, we have a daily system-wide huddle call. So every day, from the leaders, from the CEO down to the supervisor level, we have a system-wide huddle call. There's probably about, I'm guessing, probably about 250 people on the phone. I lead that call. If your unit has had a fall in the last 24 hours, you're to report it out. So it's really, this is looking back 24 hours to the next 24 hours, looking at safety, quality, service, throughput, those type of things. But if your unit has had a fall, then you will be reporting on that, saying getting to that why, because we're teaching the staff why did the patient fall, not how and when, but get to the why the patient fell. So they do need a very quick ISBAR on that fall, and reaching out to anybody on the phone that they need some more partnership. So there is that heightened awareness there. We do have physician champions on this for us, as well as clinical and non-clinical staff. We do have we have all our fall data on our intranet. We haven't quite put it on our internet, but it is on our intranet, and staff do go there because they're the ones asking for it, so we put all their fall data there. We and it's not in this PowerPoint, but what we did was we reformatted, kind of restructured our safety contract. So we do have a safety contract that we put in place, and it's really just that communication and dialogue with the patient or family when they come in. So if they are at risk for falls, they will have this contract, and it's really just reminding them that, you know, when you come into the hospital, you may not be as you know, as you're not as maybe a little bit weaker than when you came, you know, when you were at home and things like that. So just really give that dialogue and that communication between the caregiver and the patient and our family to remind them to call. It does, we have found it works to where we've had patients that said, no, I didn't get up because I remember I signed the paper that I promised I would call you. So it's really just helping them to understand that we're here for them. We want to make sure that they're safe in their hospital stay and get them home as quickly as possible. So that's what we have done recently with our fall prevention program, and I'll be happy to answer any questions.
Well, Valerie, that sounds great. Very extensive and comprehensive. I do have one question, and that is, I just wanted to clarify. So the patients or the rooms that have the sunflower on them, the leaf, the look into the room, that is every time, anytime anyone walks by that room, they are responsible for looking in. Correct?
That is
or
correct.
Is it?
That is correct. Anybody, any level, CEO down to frontline staff, including our physician, that is the expectation that we hold all our staff to. Yes.
Well, that's great. And the other question I have, I heard you say that you rolled out your education with your physicians and with your board of directors. And I just wonder, were there any pearls or anything that we all could learn from that? Oh, Karen Mack wrote this in. So how did the senior leadership influence implementation?
Well, what they did was we actually have like a town hall meeting with our CEO and some other leaderships, as well as we have what we call a weekly 30. And so every Wednesday for 30 minutes, we have our executive team, and they really just open up a phone call and ask any questions. So our CEO and that executive team did talk about the fall prevention when we said, you know, blooming, when we said July 18th, when we went live with all our interventions and stuff that we implemented after all our education, talked about it on that phone call and said it is, you know, that we, you know, basically they need to walk the talk, and they put that out there saying that this is, you know, they fully support this, that when they're in the hospital doing their rounds, that they would do the same thing, and that they would expect that all staff to do. As far as the physician group, it was the same. We went to there, and they were very supportive of it. They said, you know, go to these meetings, get them engaged. So we went all the way to the Med Exec Committee, and then we went to other committees, medical committees from there, and actually they were just as supportive. So and we're holding everybody to it.
Great.
So Valerie, this is Pat Quigley's voice. Yeah, and I just want to thank you so much for presenting, and I certainly hear and just value so much your leadership, and we're so thankful. I hope you'll let Bonnie know how thankful we are for her preparing the presentation, being part of this all along. And my question for you is, I know you have a different process for mental health units. And in mental health units, we know everybody's at high fall risk. So do you have any way of being able to notify people that are taking care of those patients of anyone who's come in, like the geriatric psychiatry patient who maybe already had a hip fracture or is anticoagulated, you know, getting to that higher level of where they need to do something different for them because they're all high fall risk. Do you have any system for that?
Well, you know, we haven't gotten to that point yet, and part of it is that I know when the previous presenter was up there talking about the Morse Fall is more of a screening tool and not an assessment tool. We're actually looking at an assessment tool to do a deeper assessment on the patient, but then do what interventions are we going to do to make it more specific for that patient population. But we do have a geriatric psych unit in our smaller hospital there. And yes, those patients are more fragile, and sometimes you get it. But I think certainly getting this heightened awareness, I have to tell you, is so important. And hearing it from the top we are committed to this just as much as you are, and we want to keep our patients safe by preventing it. Has done a great deal for us, but we do need to make it more specific, and that's what actually part of our phase 2, what we're doing, and how do we get there to keep that patient population safe, and doing a little more specific interventions for those patients.
Well, that's really great, and I hope that you'll continue to roll out that and evaluate that rapid response team, because sometimes it's really important, like if someone, for the rapid response team to respond to someone who maybe had a syncopal episode, and there may be times where you don't really need to have that rapid response team if someone just slipped on a spill or tripped over tubing, with the lesser of them, if you will, because it gets down to resources. But you have such incredible support and everybody engaged. Just congratulations, congratulations, congratulations.
Thank you so much.
Thank you very much, Valerie. We really appreciate the pearls that you shared today, and it was very insightful. So thank you very much. Next, I'd like to invite Eileen Jensen. Eileen is from Santa Rosa Memorial Hospital, which is up in Northern California. She's a clinical specialist there on the medical surgical unit, and she is going to talk to us a little bit about what they are doing in regards to preventing falls with injury and spreading some of their practices. So, Eileen, please share.
Good morning or good afternoon. Thank you, everyone. The 2 presentations were excellent, and I've made notes already of things that I want to take back. I wanted to also just comment on this entire process. I think this has been really helpful in making us all be more aware of some of the things we can do to prevent harm. We are at Santa Rosa Memorial, which is a level 2 trauma center. We run at about 200 beds, have a very active ICU, and we also have an acute rehab unit and a very busy ED, as well as labor and delivery OB and a pediatrics unit. What we have found is that we are below the CalNOC average for falls overall, so we're keeping our numbers, we feel, down. However, we're very concerned about the patients who fall and have harm. We've done a lot of work in the last... Yes?
Excuse me for a second, Eileen. I'm sorry, but we're getting an echo when you speak. Are you on the phone?
Or not on the phone. I mean, I'm just on the speakerphone. Should I try that?
Okay. Well, no, you can. It's okay to use that, but make sure your speakers are off on the computer, because otherwise it echoes. If it's yours in
maybe
both
that's
places.
what's happening. Is
Right.
that better?
Yes, that's much better.
Oh, great. Thank you. I didn't realize they were on. Okay. So as I was saying, we did a lot of work a couple of years ago to really reduce harm, and that's when we started using low beds for our patients who were very high risk, had a previous history of falling based on work that Pat shared at her presentation up in Seattle, low beds with mats that we rent and bring in. And so we did a lot of work on our med-surg units around this, but what we found is that we didn't focus as much on our other areas. And one of the areas that we are looking at now is our ED, because we've had several falls in our emergency room with patients who were ready to be discharged but had been, on the gurney for a couple of hours, probably had some meds, and went to get up and were dizzy, even though they felt everything was fine for them to go home, and they did this little road test that they do with them, and we have had several falls in that situation where the patient was left alone to get dressed, or the patient was being ambulated out, like by their parent, and then they fell. One patient fell and broke a toe. So we started looking at this. We had another patient that was transferred from our ER into our radiology for an exam prior to having their fall risk done, which is not our process, and then had a fall with significant harm in radiology. We do have a ticket to ride program that we use on our med-surg units, but the ER wasn't using it as religiously. So we've gone back now, and our main focus over the last couple months has been working in our ER. So we have implemented the ticket to ride so that every patient that comes in to the ER, the fall risk assessment using Morris, the fall risk screening, is done immediately as they come in triage. And then the ticket to ride is done, which is a little, basically another handoff used with the handoff from the ED staff to the transport staff taking the patient to radiology for an exam. Then as well, we are now just putting in alarms in our ER. We had a pretty open ER, and then 2 years ago, it was remodeled so there's all individual rooms. So you can't do that scan of seeing patients that are at high risk for, falling out of a gurney or getting up, impulsivity, and that kind of thing. So we are just in the process of putting alarms in and working out the criteria for that in our ER this week. So there's been a huge initiative with a lot of buy-in from the ED staff and some really strong champions in the ED, which in one of the previous presenters mentioned how hard it is to get champions. So I'm really welcoming the staff in the ED and want to get them the tools they need to help them roll out their program for the safety. One of the other things that we have seen is a huge change in our behavioral health population. So we are seeing a lot of patients who refuse the bed alarm, refuse the gate belt, and this kind of thing. And then we are also seeing, along with that, we're seeing our staff getting injured as well as the patient in some of these cases, even though the staff is following all the protocols that we have in place for standard work. So that's a place that we're going, and I'm looking for more support and guidance in how we might be able to keep those patients safer. So that's kind of an overview, and I think what we did, we were focusing so much on our med-surg units, we weren't looking at the outside units as much, and so we're kind of going back to look at our OB, radiology, critical care, and our OR. And, of course, the ED is our first stop on that path.
So, Eileen, thank you so much for sharing. Really, really appreciate it. And what an important aspect, looking at the emergency department. Your challenges going from open EDs to more private or segregated rooms is a challenge that we're seeing in a lot of hospitals today as they have moved into new facilities, et cetera. My question to you would be regarding the handoff communication and the ticket to ride. I know that, isn't that what you said, you use a ticket to ride?
Correct.
And so some hospitals, I know quite a few hospitals have that. And so tell me, does that take, how does that work, that ticket to ride? Is it a direct communication or is it?
It's actually on paper, and we could do electronic, but we are sticking with the paper so that the nurse fills it out, and there are very, simple questions about the patient's fall risk, and including are they oriented, are they at risk, have they had a previous fall, are they medicated, what kind of special precautions are needed, and that kind of thing. And the nurse fills it out and then shares it with the transporter, and the transporter initials it as well as the nurse, so that they have that information to take about that patient when they do the transport.
Excellent. That, Pat, it sounds like they're right on for those high-risk categories that you've talked about in previous webinars. So I think that's great, Eileen. Thank you for talking about that a little bit more. Pat, is there anything you'd like to share on this?
Yes, absolutely. And Eileen, thank you so much. It's just such rich work that you're doing, and I really applaud you for going after floor mat use. Have you been able to deal with any, have all of your staff been accepting of the floor mats, or have you encountered any barriers to
It is a challenge, and thank you for bringing that up. We have, actually, our vendor is in here about every week doing an audit for us, and we're probably at about maybe 70% of mats being down. So we work a lot with our physical therapy and trying to encourage them, because they were one of our actual biggest barriers in using the floor mats because they felt they were in the way. So we've been talking about how they reduce harm, even though, and we can easily move them. So at this point, that's our goal, but we do keep them on the floor with our low beds. We have not been implementing them with our high beds, because those patients who are at extremely high risk should be in a low bed, for the most part. as far as we go. But we are doing a lot more work also in our acute rehab unit. We've had a couple of serious falls there where physical therapy and nursing work very closely together, but for some reason there's a gap on them all being on the same page as where, or along with standard work. For example, a chair alarm not being on a patient who had a very serious fall who's a patient on anticoagulants as well. So we are, we're working diligently with that.
Yeah, and I'd love to encourage you to really keep track of the format implementation, how you got started, the implementation, the DARES and the facilitators, because usually the resistance is from the nursing staff. So when it moves into other departments and how you work with other departments, I think creates more opportunity for contributing to the success. So that would be really wonderful for everybody that's presented, but to be able to publish this work on how you were able to really go after the intervention for injury reduction is just prime time. Because, all of the Sentinel Alert that came out of the Joint Commission in September 2015 about going after injury reduction, this whole issue of protecting from hip fractures is huge. So I'd like to really encourage your team to go forward with that, to really keep on top of that as one of your primary interventions for reducing injury for an at-risk population, because that is highly publishable. And then for OB, there is an OB, there's a fall risk assessment tool for OB. I think it came out of UCLA. So if you send me an email, I can send that to you. And I'm glad your ER didn't go after a fall risk assessment tool that you really are moving into identifying specific populations and doing something different. But lastly, the whole issue of refusing things, is always a great opportunity to focus on patient autonomy. So, helping them to know if it is someone who really should have a bed alarm, like they're cognitively impaired and immobile or have impaired mobility, but they're impulsive, if that person is still refusing a bed alarm, is how do we help convince them that safety trumps that decision to not accept it versus people who are cognitively alert who can choose and have a right to choose not to do something, as long as we help them understand what's the consequence of that choice, just like the gate bell kind of a thing. So that's just a really rich opportunity, too, is to help focus on autonomy for people who are cognitively alert versus people who are not. But well done. Thank you so much, Eileen.
Great. Thank you, Pat.
Of course. Absolutely.
So I'd like to just, Pat, maybe you could just give maybe a 5-minute overview of the slides that you put up here. And then,
absolutely.
While you're doing that, I would like to ask the group to please chat in any questions you may have. And that way we'll have some time here, Pat, to review any extra questions. And there's a couple, I want to be sure we get our polling questions in at the end also. Okay?
Yes, absolutely. And just briefly, colleagues, because we really want you to have more time to be able to interact with our faculty members who have presented as well. But, the slides that we have attached here to the PowerPoint presentations from our colleagues, it was a continuation of our presentation from the last session that we had, was to really focus on the mobility issues, and then not just mobility but also gait, going after that postural hypotension. I think we've covered over time the etiologies of falls, but there's so many issues surrounding mobility. And you'll see in the slides that there is a refresher on what happens with normal balance, but what happens as we age is how our balance changes and how our gait changes. So I think what's really important, and I think we've done a lot of this focus over time, is to return our nursing staff back to clinical practice. So what you'll see in the slides is some guidance on helping people to be able to actually just observe someone and how they walk, how they transfer, how they're able to maintain their balance when they're standing. There's some guidance to help with visual acuity, and making sure that people can see. I ran falls clinics for years, and we checked everybody for impaired depth perception, but not many people do that. But, if they have problems with depth perception, they're going to have trouble being able to know where their foot is when they change from one level to another. So, this whole focus on clinical assessment, I think, is really, really important. And I have some suggestions for you for actual tests that you can do for mobility assessment. There's a timed up and go that a nurse can do. It's a 8-foot one and a 10-foot one. You watch someone get up from a chair and go around a cone or a marker on the floor 8 feet away or 10 feet away, and you can tell if they're have impaired mobility, but many of us know just by watching someone sit down on a bed or sit down on a chair how they sit. If they plop onto a chair, they've got trouble with weakness in their lower extremities and, need to have a higher height seat and then also need to have arm rests so that they can push off and stand up. But you'll see some things that are really easy to do. The chair sit-to-stand test, how easily they can actually get to a standing position while they're sitting. That chair sit-to-stand test is a functional component that's actually in the Hendrick 2. When Anne went ahead and Dr. Hendrick modified her and changed the psychometric testing and the variables on the Hendrick 1 to the Hendrick 2, she actually added that functional component, the chair sit-to-stand. So there's an awful lot you can tell by watching someone walk, doing some very simple screening tests for mobility. But don't forget the helping nurses return to a neurological exam. There's so many things that contribute to the fall component, and one of the things that we have probably not spent as much time on is sensory neuropathy. And we take care of a lot of people who have diabetes or they're on medications where this could be a side effect. But if people have trouble being able to feel their feet or be able to know if their big toe is up or down when their eyes are closed, which is about proprioception, then they're going to have impaired gait. And every one of us as a nurse learned how to be able to check to see if people can feel their legs or their feet when their eyes are closed, to be able to check for proprioception. We also learned how to be able to do range of motion tests. So there's a lot of things that we can do, reflexes, and returning back to clinical practice. So I hope that I've drilled down over the time we've had together about going beyond a yes or no response to fall history. And I gave you in one of the slides the SPLAT acronym, S-P-L-A-T-T, which is really fun. And so, people don't just splat when they fall, but the SPLAT acronym is to ask a little bit more in-depth information about the fall. Symptoms that they had before that fall, any previous falls that they've had that have occurred, where they've been falling, the activity that they were doing at the time of the day, and if they sustained any trauma. So that might be able to be a fun acronym for you to roll out in your fall and fall injury prevention programs. And then there's some information there from environmental assessment. And when people fall, it is oftentimes an interaction of the person within their environment. So don't underestimate the role of your environment of care and how that can contribute to someone falling. Whether you're keeping people in low beds all the time, or just like the difference of helping to rise the bed up to a proper height for that patient to be able to help them safely sit up or stand up or transfer. And if they have assistive devices to help them use, make sure those assistive devices, if they're using them at home and they're safe, to have them within arm's reach if they were to get up without you. So there's lots of opportunities. And then in the very end of the presentation, Martha, what I added is to integrate fall prevention into the safe patient handling and movement work. So I think that really covers the bit that we have in there. But I just want to thank everybody, and especially Martha, for working with you over this time. And then Shweta as well for pulling together all of our webinars. It's just been wonderful to be with everybody, and I can't thank you enough.
Well, thank you, Pat. I'm sure that I can honestly say that California patients are richer and based on our learnings that you have shared with us. So thank you so much for all your time. So to kind of recap for today, we had, what do we call it, 4 different colleague stories. We started with Will, who talked about really her work with the front line, and Valerie looking at, the engagement of leadership, and then Eileen, as we talked about the spread and the use of the mats, and then Pat, as she brought forth some of those different experiences that she shared with us. I did have a question, Pat, from one of the hospitals a while ago, and the challenge really with those psych patients. And I'm wondering, I know we talked about it briefly, you mentioned it briefly, but do you have some resources that you could direct us to for those patients?
Absolutely. On the Vision 8 Patient Safety Center website, which is where I was in Tampa, there's
Yes.
I developed a unit peer leader manual for inpatient psychiatry to get your unit-based champions for inpatient psychiatry. I developed a handoff communication tool for psychiatry, so the nursing staff in psychiatry, to make falls be a top priority on handoff communication, not just saying someone's high fall risk. That doesn't mean anything. So I developed a handoff communication tool that's there. And also, what else did I do for psychiatry? I think that those are probably the two things, but the unit peer leader and I redesigned the organizational assessment tool for inpatient psychiatry. You know, where you look at the important
Right.
attributes of a program, and I modified that for psychiatry. And I've published, I've published the work that I did with all the VAs in Florida and Puerto Rico and psych. And I've done a qualitative and quantitative research. So all of that is available. That's in the literature.
Excellent. Well, thank you so much. Those are
you're welcome. Yeah, I did a year's worth of work in psych. Yeah.
So, well, thank you so much, Pat. Now I'd like to go ahead and go to the the last couple polling questions. And for those of you that are still on the call, we did a little bit different format in that these were more coaching calls, and we picked one topic and then had a series of different focus on that topic over this 4 to 5 month period. And so we would just like to know if you could tell us, would this experience of these webinar series be more helpful for you if there were more real experience sharing by participants? Would it be better to shorten the length of the webinar to 30 minutes? Or any other suggestions you may have. And I would really ask you to chat those in. Even though we go on to the next question, you can still chat in any responses that you may have in regards to this first polling question. So, Shweta, if you could put up the next polling question. I'm sorry, I guess to advance it. Thank you. And then our next polling question asks that the coaching series of taking one topic into a series of focused webinars is an effective format. Would you agree with that? Or, yes it is, no it isn't, or 5 webinars is just too long. But just want to, again, get some real life experience from those of you that are out there and feedback on if this works or doesn't work. So.
Martha, this is Pat. I'd like for people to respond too. I know that, this is the last one, but if you really thought having the follow-up webinars after a conference, for those of you who actually went to the conference, really helped you with coaching and mentoring, to give that feedback back to Martha, because that was our intent. So we really want to make sure that we met our goal in helping, because we didn't want to just present at a conference and leave. We wanted to stay connected to you. So if this method was helpful, I think that I would love to hear that, and Martha, I know you would.
Right. That is what we're trying to get at, and so please feel free to type your responses in, because it is very important to us as we move forward in developing the educational plans for the next year. So, oh yes, and then also I've received questions over the series that on whether or not we have recorded these events, and we have, and so they are available on our web link, so, which is off to the left under the PowerPoint. Also, just to remind you that you can submit for CEUs. Please be sure and type in your name and where you're from, and so that we're sure that we have that you were on the call. Any other questions or comments? Well, I think we're going to give them the gift of time, Pat. Here I pushed you. And we're going to give them the gift of time, the gift of time of 5 minutes. And again, thank you so much, Pat, for being so willing to share your expertise. Yeah. All right. Have a great day.
Too. Thanks, everybody. Enjoy the rest of summer. It's been wonderful. Thank you. Bye, Shweta. Bye-bye, everyone.
Thank you.
Thank you.
Absolutely. I'm only an email away.